as Chantry mentioned, my name is Nicole Bryan. I'm one of the infectious disease faculty here, and I work in our positive health clinic, helping care for HIV patients. And then I'm also the regional director for the West Virginia partner site of the Mid-Atlantic AETC. So today we're going to try and focus on just approaches to altering ART therapy, sort of some of the rationales that we would use for that. I can't really be comprehensive because there's just a lot of tailoring that goes into selecting regimens for patients. I'm mostly going to do it through patient cases, so hopefully it can be interactive and you guys can kind of share your thoughts on some different situations and hopefully have some learning points as well. So objectives, so kind of look at some clinical scenarios where we would consider doing a simplification or a change of a patient who's already on effective HIV therapy, looking at either treatment failure, side effects, or patient preferences. And then kind of look at some of those characteristics and issues that for patients with HIV, including whether maybe it's other comorbidities, adherence, viral load, any resistance history, that type of thing that we take into consideration when we're making those changes. And then look at some of the techniques for involving patients in that decision-making process to make sure we have them on whatever is going to be the best for them. So that's kind of a roadmap a little bit. I did want to have just a few slides looking a little bit at just some very basics for antiretroviral therapy. I realize these aren't really classes of medications that a lot of providers are as familiar with or prescribing on a routine basis. So try and at least hopefully give us an opportunity to kind of a construct for how we approach ART. So some of the considerations that we have, so the one of them is really, is it effective and is it going to be durable? So can we get patients' viral load suppressed on this medication, and can we keep it suppressed for very, very long periods of time? We're talking decades. So somebody might be diagnosed with HIV in their 20s, and we need to keep them on some type of treatment, till their 60s or 70s. It's lifelong. So is it effective, and is that effect long lasting? And the answer with today's regimen is yes. That answer, in the mid 80s up until mid 90s was no. It might be effective for a short period of time, but eventually the virus would adapt and develop resistance. But current regimens are very potent and they are durable. Does the patient have any baseline drug resistance? And this can occur if they're treatment experienced, if they've been on earlier regimens, if they were diagnosed a long time ago, or truthfully, anywhere from 18 to 20% of patients with a newly acquired infection do have some baseline resistance because we have had treatments available for that long. So any type of any known resistance, we always presume that resistant virus is still going to be there. Tolerability, this is a huge one. Are the patients able to take it? It's not going to work if they don't take it, and they're not going to be able to take it if it makes them feel bad, if they have a lot of side effects. And then do they have side effects in the short term that eventually get a little bit better, or is it kind of a lingering side effect? How convenient is it for them to take? How many pills do they have to take? How many times a day do they have to take it? Most of our first-line regimens are currently going to be one pill once a day options. But we also have some long-acting injectables, which we'll touch on those as well. Preserving future options. Most of our medicines are pretty durable, and we'll talk a little bit about barriers to resistance, but we do take into consideration, is this patient really going to reliably be able to take their medication every day or when it's due? If we're in the case of long-acting injectables. So we have to think about, if they're going to miss a dose, could they require resistance? And then we may lose options going forward. So that's a consideration when we're picking or adjusting regimens. Patient factors, how advanced is their HIV? How low is their CD4 count? Are they at risk for any opportunistic infections? Do they have any associated illnesses? What other medications do they need to be on that may interact? Those types of things. And of course, access and cost. Do they have insurance? Is the medications we would like to use available on their insurance's formulary? And then are they going to be able to get them filled at their pharmacy? Are they going to be able to store them if they're having any, if they're unstably housed or things like that? How are they going to store their medications if they get their prescription filled? So those types of considerations. So lots of it kind of goes into the decision-making process as we try and find the best medications for each patient. We do have a lot of options. This is just kind of a snapshot of all the different targets throughout the virus life cycle that we have for HIV. So anywhere from where the virus first attaches to the surface of the cell, so when it first makes contact with its target cell, to when converts its RNA into DNA, integrates in the host cell genome, and then starts budding off. We have different agents all along the spectrum here. So we have lots of different options, lots of different viral targets as we've learned more and more about the life cycle. I'm going to kind of focus on big classes of this, but just so you know, there are different options out there. Some of these, like a CCR5 inhibitor or a fusion inhibitor, a lot of these are what we call kind of part of salvage regimens. They're not really necessarily used every day, but patients who are treatment experienced or have a lot of resistance, there are some things we keep in our back pocket. So in building, so this is a classic ART regimen. I'm going to say classic because I'll show you that it doesn't always look like this all the time anymore. But classically, when we're structuring an antiretroviral therapy regimen, we have what we call sort of our base here. And that base is almost always going to be two reverse transcriptase inhibitors, and it's really going to be ones that are we call nucleoside or nucleotide, where they're mimicking the active site of where the reverse transcriptase enzyme wants to bind in order to change the RNA from the virus into DNA. That's what makes it a retrovirus. So we usually have a backbone of two of those, and then a third agent. And it's really the addition of this third agent in the mid 1990s where we really started to talk about highly active antiretroviral therapy, or HAART, if you're familiar with that terminology. It was really the ability to have a third class, a third agent to add to this backbone that we were really able to keep the virus suppressed for long periods of time. So that third option, it can be another reverse transcriptase inhibitor that functions at a different site. It can be a protease inhibitor, or PI, or an integrase inhibitor. Those are the main classes that we're looking at. This is just a side-to-side comparison of looking at those different agents. So all of them you can see are have daily or twice daily dosing options. So this is a big change from early in the mid 90s where they might have to take the medications multiple times a day or even set their watch to when their dose would be due. All of them do have formulations available that are co-formulated into one pill. So this is where we have 2 or 3 medications that the pharmaceutical company combines together into a single pill for the patient to take. Particularly in the area of reverse transcriptase inhibitors and protease inhibitors, we have probably going over 20 years of follow-up at this point, probably more, and similar for integrase inhibitors. So we're gaining a lot of experience with these agents. As far as side effects go, there are occasionally some CNS side effects with certain of the reverse transcriptase NRTIs. The main one there is efavirenz. If you're familiar with that, it was a component of ATRIPLA. It's not usually really used too much in the U.S. Currently, but it may be used globally. Can all have a drug rash. For protease inhibitors, they can have GI upset. We also have to keep an eye on their lipids. And then there's also a lot of issues with drug interactions with this class of medication. And then side effects for integrase inhibitors we're seeing as we're using them more and more, there's a side effect of weight gain that we see with that class. As far as barrier to resistance, the NNRTIs are probably, I guess, the weakest as far as that's concerned. So it doesn't take a lot to burn out an NNRTI, which is what we saw early on when they had the era of AZT and patients would lose their AZT through developing resistance mutations. That happens fairly quickly. The protease inhibitors and the integrase inhibitors actually have a higher barrier resistance. Protease inhibitors definitely have a very high, that's one of the highest ones. Integrase inhibitors, particularly the newer ones, if you're familiar with like bictegravir or dolutegravir, those medications probably are relatively comparable to protease inhibitors. We just don't have the data, but they're very, very similar. And so NNRTIs probably have the highest baseline resistance in the community, whereas protease inhibitors and integrase inhibitors to date, it's pretty minimal. So just to kind of give you a comparison across some of those drug classes. I hinted that that was sort of our classic approach to it, and most patients who are diagnosed with a new infection today will be started on a 3-drug regimen. But we do have 2-drug regimens that are available, and these are specifically with integrase inhibitors. And so specifically with one called dolutegravir. So it's pretty potent, high barrier to resistance. And if you combine it with just one other drug, it seems to have lasting impact and lasting viral suppression. So there's two FDA approved ones. One is dolutegravir combined with the NRTI lamivudine, and then dolutegravir combined with an NNRTI rilpivirine diluca. So sometimes patients have, why would we approach that with two drugs instead of three? Sometimes patients have can't have the backbone either because of kidney issues or adverse side effects. Usually kidney issues is the main one. And so, or just tolerability, they may have side effects from it and they don't feel like they can take it, or just to decrease the number of medications that they're taking, the long-term implications. So those are some indications. So we do have some two drug options available. So if you happen to see a patient where they're only taking two drugs, that doesn't necessarily, if it's one of these, it doesn't necessarily mean that it's wrong. And it does minimize those long-term consequences and side effects. The biggest contraindication to anything I mentioned that's only a two-drug regimen is going to be hepatitis B co-infection. You guys have probably talked about that in the context of hepatitis C throughout this series, where if you treat a patient who has both hepatitis B and C, and that you treat the C, the B can flare. The same concept can happen in patients with HIV. So some of our HIV medications have hepatitis B activity. And so the current recommendations is they be on at least two agents that have that hepatitis B activity. And if you change them from something to from where they have two drugs that have activity to something that doesn't, that's another situation where you can flare their hepatitis B. So that's a contraindication to doing that. Or if they have known prior resistance. Is there a question? That's great. Um, that's just kind of a little bit of background, hopefully get you familiar with sort of conceptually the different classes of medication. So now I have clinical scenarios. So hopefully we can talk about a few patient cases and situations and how we would approach changing ART in these circumstances. All right. All right, so the first patient is a 42-year-old male who's coming to clinic for follow-up. He was initially diagnosed with HIV about 15 years ago on routine screening. And his initial regimen consisted of tenofovir, the TDF formulation, emtricitabine, and efavirenz. So that's an NNRTI, and that was co-formulated. I do have the brand names here just because sometimes they're easier, people are more familiar with them. That's the brand name Atripla. Due to significant side effects and then some newer medications, in 2017, he was transitioned to the updated version of tenofovir or TAF plus emtricitabine, and then a newer integrase inhibitor, raltegravir. Over the past couple years, though, he's struggled with adherence because of work-related stress, and he's had some depression, and he's also had some difficulty attending his clinic appointments. So his laboratory studies today show that his total white blood cell count is normal. It's 5.7. Hemoglobin's good. Platelets are good. Creatinine's normal at 1.0. AST and ALT, his liver enzymes look good. CD4 counts is okay. It's over 200. But there's his viral load at about 25,000. A year ago, these were his results. A year ago, he was undetectable with his viral load, and his other numbers were similar. So my first question is, what might you be worried about at this point? And you can put it in the chat or you can say it. I'm fine either way. So resistance versus adherence. Yeah. Thanks, Bailey. Anybody else have any thoughts? So yeah, so it kind of depends on how he's been taking it. So definitely telling you I've had a lot going on in my life. It's really hard to remember taking these pills. Oh, somebody else had a thought. Am I missing it? Or just a thumbs up? Are you helping me out, Chantry? So I don't mess up.
Yeah, you're good.
Okay. Yeah, and one of the things I didn't tell you, but the raltegravir is a twice day medication. So this patient was on a medication where he's taking one pill once a day and a second pill twice a day. So you can see how that can definitely be challenging, especially if somebody's having different work schedules and things like that. So there's definitely some adherence challenges. The other thing I'll tell you is raltegravir of the integrase inhibitors, it's an earlier one. And so its threshold to resistance is actually a good deal lower compared to kind of some of the ones that you might be more familiar with, like dolutegravir or bictegravir. So those would definitely be our concerns for a patient who was previously undetectable that now has detectable viral load. So any additional laboratory studies you might think about checking at this point? Does anybody have an idea what we might send off? I'll tell you it's a send off. A genotype. I think I saw a genotype. And then oh, there's a question. Have you found viral load takes a longer time to come down when using a two drug versus a three drug regimen? And then maybe a genotype and an HLA test. Yeah, so if we wanted to think about something like HLA-B testing for B5701 for abacavir, so that would be another backbone medication where if certain people with that genotype can have a severe allergic reaction, like a Stevens-Johnson reaction, even with their first dose, if they have that be if they're positive for B5701. So if we wanted to potentially use that, we would potentially send up an HLA. And then yeah, genotype testing. That's kind of our way to look for how we look for common resistance mutations is we send it off for analysis. We don't run it here on site at our hospital at WVU. There might be other labs that do, but we sent it's about a week to 10-day turnaround depending on the day of the week that it gets sent. But they will kind of look, they'll kind of sequence throughout the virus and look for any key mutations that they know are going to cause resistance to the current medications that they're on. As far as viral load taking longer to come down with two drug versus three drug regimen, the answer is really it doesn't. What really seems to drive whether or not how quickly the viral load it'll come down. It's just if you start at a higher viral load, it's going to take longer to get to undetectable, as you can probably see. But if you're if one patient A starts at around 100,000 and patient B starts at 100,000, and you start patient A one on two drugs and one on three drugs, they'll probably become undetectable around the same time frame. Now, that's a good question. So we'll probably definitely send off a genotype, potentially think about HLA testing, if we were thinking we might want to do an abacavir backbone. And then what would you think about what would you do with their treatment as of today? So this is a little bit more of a nuanced question. So I guess big question be, would you change it today? Would you have them kind of keep doing what they're doing? What would you do with it for today? Because I'll tell you I just told you that's going to take probably about a week or 10 days to come back. So any thoughts on what we would do today? Maybe folks just aren't sure, or they just don't want to share. So I would probably leave this patient alone until I had the genotype. And then just say, keep doing what you're doing. And then let's wait and see what the genotype shows. If he really wasn't tolerating it or consistently missing that second dose of dolutegravir, you could consider switching, but it's easier just to kind of switch once when you have a little bit of information. So especially since his CD4 count's okay, we definitely counsel him to take advice, take precautions as far as transmission is concerned. But he's probably not at risk for doing anything, opportunistic wise or anything in the short term. So I would probably wait for his genotype. So this is what we call virologic failure. So basically, a patient, is on treatment, but we're seeing viral breakthrough. So the definition of that is really the failure to suppress the HIV viral load, and we really still use a threshold of 200 copies per ml. And that's by 24 weeks after you've started them on treatment. So this patient's been on it for several years, so he would meet criteria for that. Even though our PCR studies are very sensitive now, and you can, when they say undetectable, they mean they're not, that there's nothing for like 1 or 2 copies. We still consider anything less than 200 to be suppressed, and that's kind of set by the CDC. So anytime we see a rebound beyond 200 copies after suppression has been achieved is so either they never get below 200 or they got below 200 and now they're rebounding and the question is why. So the most common reason for this to happen is non-adherence. That is by far and wide the most common reason. So the first question is, are you taking your medications? Have you been able to, have you had any issues getting your prescriptions filled? Are you having any side effects to them that you don't feel like you can take them? So most far and wide, it's issues getting the medication, either access to the medication or taking it. Sometimes there can be pharmacologic issues. So what I mean by that, that's mostly going to be like drug interactions, including stuff they might be taking over the counter, or like any herbal supplements or things like that. Or they've developed resistance to one of the agents, and that's kind of the one that we're typically the most concerned about. So how do we kind of approach them when we see evidence of virologic failure? So the first is to talk to them about adherence. Are they having any mental health concerns? Is medication cost an issue? Did they lose their job or change their job and their insurance changed, which resulted in a change on their formulary? So maybe they're not able to get it. Are they unstably housed? So do they have a place to store their medication or keep their medication safe? Have they had issues with transportation so they can't get to the pharmacy to get their medication picked up and they can't get to their clinic appointments? Or do they have really complex work schedules? A lot of people might work, day shift one week and night shift another week. So it's really hard to kind of take their medication at the same time every day, and navigate that changing work schedule. Is the regimen really complex? How many pills are they taking? How many times a day do they need to take them? The harder you make it for them to take it, the harder it is for them to remember. And then are they having side effects? Are they feeling sick to their stomach when they take it? Does it make them feel really tired? And so whenever they have, something they have to do, they don't want to do it. Most of the time, our current medications the side effect profile is pretty forgiving. But people are different and people tolerate medications differently. As far as pharmacologic issues, so drug interactions is a big one. So we do kind of check for those, and again, including you got to think about anything they're doing over the counter, or any supplements that they might be taking, and then also absorption issues. So some of our medications require acid for absorption. So if they're taking a lot of Tums or anything that suppresses their acid, that can affect its absorption. The other thing is sometimes some of those kind of minerals, those cations like calcium, magnesium, iron, can affect some of the absorption of certain medications. So that's also kind of another area to look at. Are they absorbing it correctly? Are they taking it with food? Some of them require that you take it with a large meal, at least 500-calorie meal, in order for it to be adequately absorbed. So those are considerations as well. And then resistance, we do like to look at prior treatment regimens, and also any prior genotype results. Once we see resistance to one medication, even if that genotype was from 10 years ago, we always presume that strain of virus is still present in that patient. And as soon as you put them on a medication that stresses that, it'll kind of emerge. So we really do spend a lot of time considering prior genotype results. So genotype testing, so again, this is evaluating mutation in the HIV genes that are known to cause resistance to different classes of medications. We do check it usually at the time of diagnosis, because as I mentioned, anywhere from 18 to 20% of patients who with newly acquired HIV may have a baseline resistance mutation. If there's an incomplete virologic response, so we start them on treatment, we think it should work, but now for some reason they're not getting below 200, or if they have a viral rebound that isn't really explained by adherence, and when they go back on their medication and say, yes, I'm taking it every day, it still hasn't become suppressed. Most useful if the viral load is at least 500 copies. Some labs prefer over 1,000. The reason being it's really hard to do genotype testing if they don't have detectable virus in their blood. So sometimes if you send it off and it's just barely over 200, the lab might say, oh, we can't run it, it's too low. Okay. So just a little bit on transmitted resistance. So within this was a study that looked at 36,000 genotype sequences from individuals who had acquired HIV in the U.S. from 2013 to 2016. And as I mentioned, the NNRTIs really have kind of the highest resistance there, so it's almost 12%. And that's the most common one. They have been around for a good while, but again, they just have a lower barrier to resistance. And again, for those who acquired HIV, it was around 20%. And then when they looked at that, this was another study looking specifically at California from 2008 to 2018, and the findings were similar. So it's really the NNRTIs that kind of the lowest barrier, followed by the NRTIs. Those are the backbone drugs. And then the protease inhibitors and integrase inhibitors are much lower. And then as far as genetic barrier to resistance, so I hinted that I touched on this a little bit in the introduction, but so what we consider low resistance, where a single mutation will probably mean that you've lost that drug. So that's what we have. They mean they have a low barrier to resistance. It doesn't take a lot of mutations on the virus's part in order to lose that medication. So efavirenz is an NNRTI, rilpivirines is an NNRTI, raltegravir, which is what that patient was on, and elvitegravir. Those are our earlier integrase inhibitors, not used quite as much currently. And then in some instances, even lenacapavir, the newer injectable. Intermediate, this is kind of our NRTIs, our backbone drugs, tenofovir, abacavir, zidovudine, and then cabotegravir. And then high resistance, where you need more than at least two mutations, but a lot of times more. Those are some of our other PI medications and our integrase inhibitors. So one way how to approach this. So a lot of times when you order genotype testing, it'll give you not just the list of mutations, but what drugs are impacted. So most labs are really nice. But if you're ever uncertain, or we're ever trying to compare prior genotypes, this is a really handy resource. It's free. It's through Stanford University. We use it a lot, but you have this genotype option, so you can look at what have they been treated with before, and then it has a lot of what are some clinical outcomes. But it's really nice. You can actually just go in here, type in what are their resistance mutations, and it'll tell you what it predicts their resistance to be. So some of the guiding principles when we're changing treatment due to virologic failure. So first, if the issue is adherence, we need to address barriers to adherence. So if the issue is cost or changes in insurance, we need to have social workers to help us address that. And then we don't want to compromise efficacy for convenience. So if they need a more complicated regimen because they develop resistance, then we have to figure out a way to make that work. We definitely need to account for all mutations that could have been transmitted for or selected during prior treatment courses, and then also try to construct sort of the most tolerable and acceptable regimen in order to suppress that. So there's a lot that goes into it. Fortunately, this isn't the most common scenario that we currently face, but it can be the trickiest one, and a lot of times where you need somebody with some expertise in HIV to provide some guidance. Any questions on that before we go on to the next case? Okay. All right. So the next case is a 59-year-old female coming in for follow-up of HIV infection. She was initially diagnosed in 2001 and has been on treatment since that time. And her current regimen is tenofovir. This is the older version, the TDF, with emtricitabine and dolutegravir. If brand names are more comfortable, that's Truvada and Tivicay. She has really good adherence. She's maintained good viral suppression and a good CD4 count. Her other history, she does have a history of high blood pressure, high cholesterol, and type 2 diabetes, but no prior history of opportunistic infection. Her HIV has always been very well controlled. So her laboratory studies today, normal white blood cell count, normal hemoglobin, creatinine's 1.9, so a bit elevated. Liver enzymes are normal. She does have a little bit of protein in her urine. CD4 count is normal at 610, and her viral load is suppressed. It's undetectable. So any thoughts or concerns for this patient? If anybody have any of those.
Carmen said diabetes control.
So how low is their diabetes? Sorry, I don't think I had an A1C on there. That's a good question, especially with the protein in the urine. And then how are the kidneys doing? So you definitely want to look at her trend. Like, is this kind of, is this creatinine of 1.9? Is that new? Or has it been kind of, slowly increasing over several months? Kind of how what have her kidneys been doing over a period of time? Yeah, so that's definitely a consideration. So. So any thoughts on what we might do with the patient's medications as far as her antiretroviral therapy at this time? So she's on Truvada, the TDF, emtricitabine, and dolutegravir, I believe was the other one. But it's working. She's suppressed. Nobody want to take it? Somebody want to take a stab at it?
We have nothing, keep as is, and then one person said change to a TAF containing regimen.
Yeah, so could consider updating to a newer tenofovir based regimen, from the TAF to the TDF, which should have less issues with the kidneys. Or it's working, so we'll kind of see how it is, and maybe investigate the kidney to see if there's another cause for kidney issues. So, the approach to patients when we would change their treatment in patients who are suppressed. So there's lots of different reasons we might do this. So it seems like it's working. Why would you change it? So if they're suppressed, they have a good CD4 count. Where can we optimize it? One is side effects. One is to reduce their pill burden. Is there a way to take them from two pills to one pill? Is it a smaller pill or a bigger pill that's easier for them to take? Are there any drug interactions to take into consideration? So, do they have behavioral medicine issues and they need a special behavioral medicine that interacts with their current medications? Or have they been diagnosed with tuberculosis that might interact with their current regimen? What are their other medical needs, and does it help us to make adjustments on their treatment, on their HIV treatment side to account for optimizing their treatment for other things? Risk of long-term complications. So this is something that as patients with HIV are living much longer that we're taking in more and more into consideration. Cost, insurance changes, difficulty with food requirements. So specifically, it's rilpivirine that requires that 500-calorie meal. Pregnancy, or desire to conceive. There are preferred regimens for patients who become pregnant with HIV that are better studied in pregnancy as far as are they able to be effective throughout pregnancy and also have minimal toxicity to the infant. But most common reasons are really going to be that long-term toxicity and then to simplify the regimen. So how do we look at that? So what are some of the common adverse effects? So this is looking at the NRTIs, and specifically TDF is known to cause renal tubule injury, particularly over long periods of time, and then also decrease in bone mineral density. So most patients who have been diagnosed probably 10 years or more ago, at some point, we're on a TDF-based regimen. So this is one of the things that we monitor in those individuals long term. But we do worry about kidney issues in patients who are on TDF specifically, as well as bone density loss. Tenofovir alafenamide, the TAF, that's sort of the updated version of TDF. We also have to consider that does have an association with increased lipids. So we do have to keep an eye on their cholesterol because patients with HIV are at higher risk for cardiovascular disease. Some of the others, efavirenz, that was an NRTI that is a component of ATRIPLA. So it had CNS side effects. It was usually really vivid dreams and sometimes nightmares, but more concerning, it had association with depression. Rilpivirine can also have some CNS side effects as well. So there are some kind of unique side effects and long-term toxicities that we monitor depending on which medication they're on. The protease inhibitors can also increase their lipids, their cholesterol, and also are associated with that lipodystrophy. If you've ever seen pictures of patients with HIV where they kind of have a very thin face, very thin arms, but very round midsections, that's that redistribution of lipids. That's really been something that's associated with the protease inhibitors as a class. One of our older protease inhibitors, atazanavir, was associated with kidney stones and high bilirubin. The bilirubin wasn't necessarily harmful to the patient. It actually, but they didn't like it, especially if they developed like any jaundice or any yellowing of the eyes. And then integrase inhibitors, the big one there that we've noticed as we've used them more and more is weight gain. And then they can also have a few CNS side effects and some effects on the GFR measurement, but not really kidney toxicity per se. So guiding principles really is to you want to maintain that suppressed viral load, but also help with the patient's quality of life and decrease the risk of toxicity. This is the most common reason today why we would change somebody's HIV regimen. It really has more to do with improving quality of life, reducing toxicity, and making it easier for them to take. Most new regimens are going to have pretty good potency, but to ensure that you want to make sure you look at all their prior genotypes and previous treatment history, address any barriers that they're having to resistance with their current regimen. So it doesn't really do a lot of good to switch their regimen if it's also not covered by their insurance, or if they're also unstably housed and aren't going to have a way to store that medication. And is this regimen higher or lower barrier to resistance? So all of that kind of goes into considerations. And then also, what are the potential side effects, either long-term toxicity or immediate side effects that the patients might experience? As far as comorbid conditions, so again, do they have any baseline reduced kidney function? If it's significantly reduced, we may even consider them for a two-drug option if there aren't any other contraindications. Bone density loss. Again, we're moving away from TDF-based regimens mostly because of kidney issues and bone density loss. Do they already have high cholesterol? So that might want to consider, do we want to do a protease inhibitor for somebody that already has high cholesterol? Do they have known cardiovascular disease or they have a hepatitis B infection? Decrease that pill burden wherever you can. It's always going to be easier for them to take it if it's fewer pills, and minimize drug-drug and drug-food interactions and then their cost. For a two-drug regimen, as I touched on those again, that dolutegravir, lamivudine, dolutegravir, rilpivirine, again, they can't have any drug resistance to either agent. And at least one of them has to have that higher barrier, which is in these cases, it's the dolutegravir. And then manage those drug-drug or drug-food interactions, and they can't have Hep B, as we touched on. All right. I do have a third case. Are we okay on time, Tantry, or should I stop for questions?
We're good. We are good till 1:15, so you can go ahead with
Okay.
your case.
Yeah, this is just a third case. We get a lot of questions about this particular topic, so I'll go ahead and dive into it. I think we'll have time to get through it if we're good till 1:15. So 20, or is there any questions about changing based on side effects or long-term toxicity? Any questions on that before I jump? Okay. Um, so 28-year-old male who's come in for follow-up. He was initially diagnosed in 2019 with HIV infection on routine screening. And he's currently on antiretroviral therapy with tenofovir alafenamide, emtricitabine, and bictegravir, or Biktarvy is the brand name that you might be more familiar with. Doing really well, has really good adherence, not having any side effects, but he is interested in getting rid of having to take a pill, and he wants to try something that's a long-acting injectable medication. And I will say more and more of our patients are asking about this. People really like the idea of not having to take a pill every single day, particularly younger individuals who might not have other medications that they're already taking. So his labs, his WBC count is normal at 5.9, hemoglobin's normal at 13, creatinine 0.9, liver function's normal, his CD4 count is good at 810, and he is undetectable on his current regimen. So, any thoughts on if this would be somebody that would be a good candidate to switch over to a long-acting injectable medication?
We had someone say
Yeah.
social situation or working out of town.
Yeah, that's a great question. So, yeah, so we'll touch on that. But yeah, so he really the current medications, so specifically cabotegravir, rilpivirine, for treatment, it, does have to be administered in a clinic. So if he's somebody says, yeah, Ken knew it would be a good idea. So if he's somebody who's working out of town a lot or not reliably at home or can't reliably keep clinic visits, at least every other month, then yeah, I might not be the best candidate. And then also considerations from a social standpoint is also going to be, transportation, which a lot of our patients, here in West Virginia really struggle with. So, does he have a ride to get to those clinic appointments so he can get the medication? Would definitely be a consideration. And then also insurance coverage. But those, if those things were met, from a medical standpoint, would a long-acting injectable work? I would probably say most likely. As far as any additional history or laboratory studies before we would make that change that you would ask that maybe I didn't give you. And in case you're not as familiar with it, Cabenuva is a two-drug regimen. It's cabotegravir, which is an integrase inhibitor, plus rilpivirine, which is a reverse transcriptase inhibitor. And they're both administered with an injection. So any thoughts about anything else we might do or want to consider or know about? So liver function, yeah, liver. I think we had AST and ALT, and it was okay. So yeah, liver function would be a consideration. So probably specific things would be prior genotypes. So he's been undetectable, wasn't diagnosed that long ago, but he should have probably had a genotype obtained at the time of diagnosis. So any evidence of resistance to either of those agents on the prior genotype. The other one you would want to remember, because it's a two-drug regimen, you do have to be aware of their hepatitis B status. So I don't think I gave you their hepatitis B results. So you would want to make sure this patient does not have any prior history of hepatitis B, where you would need to maintain that three-drug so that you had that hepatitis B active backbone. So those would probably be the two main things, in addition to some of the social questions, like could the patient come to the clinic and for their appointments to get the medication, that type of thing. Um, So there are two current long-acting treatment options. There are more in the pipeline. Just so you're aware that this is a lot of HIV treatment is kind of seems to be headed in this direction. So there probably will be more in the coming years. But currently, for FDA approval, there's two options. The first is Cabenuva, is the brand name. It's cabotegravir plus rilpivirine, and that's administered each as two intramuscular injections. It can be given monthly, but most of the time patients opt for the every other month option. You do start it out typically with an oral lead-in. It's probably more evidence suggests that you don't absolutely have to do the oral lead-in. It does kind of help you to make sure that they tolerate it okay, that there's not going to be like an allergy or a side effect or something like that that you're not really unaccounted for. But you don't necessarily have to do the oral lead-in for it to be effective, particularly if they're already suppressed. But technically there's an oral lead-in. Oh, is there a chat or comment? Somebody going to correct me? Oh, somebody has to get another meeting. Oh, thanks, Rachel. For lenacapavir, that's the other long-acting injectable. So most people are probably familiar with this in the PrEP space because that's where it's making lots of news and lots of headlines. For lenacapavir, it's really and it's a subcutaneous injection that's given every 6 months. So that's why it's super exciting. It has a new mechanism of action. It's what we call a capsid inhibitor that inhibits capsid formation, both right out short, both with viral disassembly when it kind of enters the cell and breaks apart to replicate, and then viral reassembly. So it's a really exciting option. You're probably hearing about it a lot in the PrEP space, but prior to PrEP, it was actually approved for treatment. For the most part, this is one that we're kind of currently reserving for treatment, highly highly treatment experienced individuals who may have resistance, a lot of resistance to other agents. So that's kind of how we approach it from a treatment standpoint. So for the most part, the main long-acting injectable option that we're offering is cabotegravir and rilpivirine. The other thing is lenacapavir is also not going to be a standalone treatment option. It's going to be part of a bigger regimen. So it's probably lenacapavir plus something else to try and get them suppressed for those treatment experienced individuals. So current guideline for use for cabotegravir and rilpivirine. So technically, again, there's data coming out that you don't have to do this, but this is the current guideline for use. So I just want to make sure you're aware. So technically, they're supposed to have a sustained viral suppression for at least 3 months. There's a lot of active research going into patients who are not virologically suppressed, but really struggling with adherence to oral medications that might do okay with this. So there's a lot of clinical research going into that particular topic, but this is kind of the current guidelines. So just want you to be aware of that. It may change as we get more data. No, they can't have any suspected or known resistance to either agent, no history of hepatitis B, not currently approved for pregnancy, and then not receiving anything that would have a known drug interaction. So some considerations for using, so you do, it does reduce the dose frequency, so that can really improve their quality of life, decrease that pill burden. Patients really kind of feel freed a little bit from having to worry about taking their medications every day, that, life might get in the way and they might forget. And then it also helps mitigate concern about disclosure of their status. So if they're not having to take medications with them everywhere they go, or worry that somebody's going to find their pill bottle, they just say, oh, I got to go to the doctor, have a quick doctor's visit and get their injection. It really helps their quality of life. As far as adverse effects, they can have some injection site reactions, so especially it's an intramuscular injection, so they can have some soreness. It does seem to decrease over time as the longer they're on it. And then those practical considerations. So it would require a clinic visit, somebody, and then a healthcare provider who knows how to administer it, and use the correct injection techniques and things like that. Might have to consider also things like needle length in patients with higher BMI, and then prepare, and then have to have sort of a management strategy if they're going to potentially miss their dose. It does typically give you about a 7-day window of forgiveness to get them to the clinic, so for scheduling purposes. But sometimes we also, might say, hey, keep like a week's worth of your oral lead-in case like you can't get here in time, so that you still have adequate drug levels to suppress the virus. Um, as far as just a general principle, so what do we do after we change somebody's medication for whatever reason, whether it's for virologic failure, whether it's they want to try out a long-acting injectable, whether it's we want, just to improve their side effect profile. So it's always good to follow up after you make that change, either a clinic visit or just a telephone call. And you want to make sure they're not having any issues with their pharmacy filling the medication. Does their pharmacy have it in stock? Or that they receive the correct medications and that they're taking them correctly. So especially if they're used to 2 pills that they're or 1 pill, or if they're used to taking something twice a day and you put them on something that's once a day, make sure that they're aware that you're only supposed to be doing this once a day so they don't get into toxicity. And are they tolerating it? Are they having any side effects or any issues with it? And then it is always a good idea to do some laboratory monitoring 4 to 8 weeks after you change their regimen. Mostly you're looking for to make sure that if they were suppressed, that they're still suppressed on the new regimen, or if you were changing it because of virologic failure, that their RNA levels are becoming suppressed. And then also check kidney and liver function for any adverse reactions on that front with the new medication. And finally, just final summary. So there are multiple treatment options for patients with HIV. So we have lots of things to choose from. The main indications to make changes in our current, if they're already on treatment, is virologic failure, side effects, long-term toxicity, decreasing that pill burden and drug interactions. We also now have long-acting injectable medications that are available, and probably some more in the pipeline along the way. And then really spending time counseling patients on the risks and benefits for different therapeutic changes, and make sure that you follow them closely and have follow-up labs to ensure that they're tolerated and effective. And just a couple of tools. So the National AETC Support Center does have an HIV Care Tools app that can help. And then there's also an AETC newsletter you can sign up for. as well. And then if you're also interested, there's a national clinician consultation center if you that's free to no cost. If you ever have a patient in clinic and you have a question, they can be a good resource. And if you want to learn more, there's a national HIV curriculum that provides free CMEs and CNE credits at no cost that is really very well updated and very well put together and very thorough on things related to HIV. So that's all that I have. Anybody have any questions or comments?